Hello friends, I'm back after Diwali. Hope you all had a nice Diwali. You must be wondering why I'm repeating this topic, failed induction, and I have added a caption also that is newer perspective. What has changed in last 10 days? I just took this class 10 days ago. I always watch the videos after I finish the class and I critically evaluate myself. It was not bad, but what I realized was that some of the explanations that I gave, some of the analogies or some of the things which I gave were not up to my satisfaction. Secondly, I read through it again and I researched some more because this is a highly difficult subject and there are a lot of controversies. And I had to understand it properly to give my perspective on this. So that's why I thought best is to repeat this talk so that I have a better recording and so that I can upload it. But I'm of late facing some difficulties in uploading also. That's why I'm requesting all of you to attend the class as much as possible. Sometimes it is not possible for me to upload also for technical reasons. Anyway, let's not waste time and let me straight away go into this topic again with a newer look or a newer perspective. I have rearranged the slides also in order to make a better flow of thought and better understanding of the subject. When we say a successful or a failed induction, there should be a criteria so that the research will be uniform throughout the world. But unfortunately, although the definition for induction of labor is simple and straightforward, the criteria for successful or failed induction of labor have not been standardized. And no consensus has been reached to date. So you must be thinking, what am I going to talk then? If it is not standardized, if there is no consensus, what I'm going to say? So that's the thing. That's what I kept on reading last 4 days in Diwali and try to understand and try to give a better view of this to all of you. I hope at the end of the talk, you will agree with me. The outcome of induction of labor itself is controversial in the sense a variety of endpoints have been suggested. Obviously, when we induce labor in a person who is not in labor, the ultimate outcome, we want her to deliver via vaginal route. Otherwise, we would do a cesarean section, isn't it? The whole purpose of labor is to make sure that it pushes out the baby through the vaginal route. To do a cesarean section, you don't need labor. It is as simple and as straightforward as that. So obviously, the first few views were the outcome was measured in terms of mode of delivery, whether she landed up in vaginal delivery or she landed up in cesarean delivery. If it was vaginal delivery, then only it was considered successful. Otherwise, it was considered failure. It's not as simple. There's problem in this. I'm going to discuss that further in the next slide. Suppose the end point or the outcome should be vaginal delivery, then you have to define a timeline, isn't it? The vaginal delivery within a certain time interval was considered as a good outcome. What is that certain time is another problem. But then of late, people have started thinking that yes, the ultimate goal of induction of labor is to achieve vaginal delivery. But when you talk about induction of labor, its success should be whether you were able to induce labor or not. I mean, the immediate success. So the definition was sort of reframed, or the endpoint was reframed, whether you could achieve the active phase of labor. Let me give an analogy, which I other day didn't give. Today, let me give that analogy. Now, the purpose of inducing ovulation, obviously, to make a lady pregnant. But we have seen, in spite of inducing good number of eggs, 10 on each side, ultimately she may not become pregnant. So it's not just the induction of ovulation which determines the pregnancy. The sperm should be good. Even if you do ICSI, we know that less than 50% of them will have final fertilization. And even if you successfully transfer the embryos, again, half of them may be taken up, implantation occurs. So there are wide variety of things in achieving a final clinical pregnancy. But induction is a starting point. So you cannot say the purpose of induction is to achieve pregnancy. That's why if she doesn't achieve pregnancy, induction has failed. It's wrong. Induction has been successful. Inducing ovulation has been successful. But the final goal or the primary goal that she should become pregnant has not been achieved. But that has got so many other factors. Similarly, when your main aim is to induce labor, whether you have been successful inducing labor or not should be the end point, rather than whether you achieved the final goal or primary goal of that is landing up in a vaginal delivery. Because we know that even in a natural labor, nobody can guarantee at the beginning of the labor that she will have a successful vaginal delivery. Even though we have ruled out CPD, we have ruled out all other factors, there are certain things that can happen in the course of labor. For example, a fetal distress, or for example, some other things, a missed CPD. So you may finally land up in doing a cesarean section. That is different, isn't it? So that's why we have to clarify. Yet, I thought of one more controversy for myself, and I thought somebody may ask this question. So I have thought of this question. Let me answer that. What is that question? When it comes to inducing ovulation, same example or analogy which I said, with respect to clomiphene, there are two terminologies: clomiphene failure and clomiphene resistance. We say clomiphene failure when, in spite of inducing ovulation, pregnancy has not been achieved. So how do you answer that now? And clomiphene resistance is the true sense of failure of clomiphene, in the sense the clomiphene has not been able to achieve induction of ovulation. Now let me explain that again. Yes, you may call clomiphene failure when she doesn't achieve pregnancy, but then why they have brought in another terminology, clomiphene resistance? Because in spite of achieving induction, clomiphene we know that is not very endometrium friendly, right? So it has not achieved pregnancy in spite of ovulation induction. That's why they have brought in even though successful induction has occurred, it has ultimately failed. Whereas clomiphene resistance means we are not thinking of endometrium at all. It has not been able to produce any eggs. And so you have to apply different strategies for that. I hope this much of explanation has clarified everything. So let me move on. The problems with delivery as outcome, as I just explained, to put it in words, that vaginal or cesarean delivery depends on many other factors interacting during labor, which are not necessarily related to the induction process. So induction process ends when you have achieved active phase of labor, 3 contractions per 10 minutes. And of course, according to the latest guidelines, that is WHO Labor Care Guide, I'm going to talk about the literature. But after that, many things may change the course of labor, and you may be forced to do a cesarean section. That does not mean that you failed in achieving induction of labor. Even though the primary intention of inducing labor was to achieve vaginal delivery, I didn't want labor to do a cesarean section, but not other way around. Just because I achieved labor, I need not always land up in vaginal delivery. There can be a different reason to do a cesarean section, not failed induction. I hope I'm very, very clear in this concept. The other difficulty is that majority of guidelines do not specify a time limitation from the initiation of induction of labor to delivery. See, labor care guide has told us a time frame from the active phase to the delivery, which is maximum 12 hours. But nobody has given us a timeline from the time of initiation of labor induction to the delivery. That is why all these problems. Okay. Now, what is the need to diagnose failed induction? Why I'm so much particular about defining, teasing everything threadbare? Because it helps in counseling the patients. Nowadays, everybody is restless. This is the time of instant things, instant noodles, instant success, instant lottery, instant promotion, instant richness. So you induce here and they should deliver there. That never happens. So you need to understand when exactly you call it failed, and that's why you may stop inducing labor and go in favor of cesarean section. That has to be understood by us. Then only we can counsel the patient properly. Otherwise, we may be prematurely stopping induction, or we may be eternally inducing, waiting indefinitely. Both are wrong. So decide whether to continue with induction of labor or to perform a cesarean section. To say, no, I give up. That's why we need a point. We need a definition of failed induction. So how do we achieve that? What should be the measure of success? I have already given enough preamble now. So let me come to the specifics. As I already explained, since the purpose of inducing labor is to cause a non-laboring woman to go into labor, I'm not talking about the ultimate aim, that is vaginal delivery, but the initial aim is to push her into labor and see whether the labor can give me vaginal delivery. Okay, if she's not in labor, of course, there's no question of vaginal labor at all, vaginal delivery at all, cesarean section. But here I'm trying to see, after inducing labor, she may progress into vaginal delivery. But first intention or first purpose is to make a non-laboring woman into going to labor. So a reasonable measure of success would be to achieve active phase of labor. So this is very clear. Now, after this, these thoughts have come. It also should be based on low probability of entering into the active phase of labor. Because if you wait for an indefinite time and then you declare that now it is failure, is not correct. So you should also have a probability of entering into active phase of labor. And what? Without increasing the adverse outcomes. That's why Arul Kumaran and Talokila in 2011 came up with a wonderful definition of failed induction of labor. That is inability to achieve cervical dilatation more than 4 centimeters, because that time in 2011, the active phase was considered when she achieves 4 centimeters. After 12 plus or minus 3 hours of oxytocin, because that time also the mode of induction was mainly by oxytocin administration. But now, Muralidhar Pai, that's me, in 2022, based on WHO Labor Care Guide 2020, I would like to change this number from 4 centimeters to 5 centimeters, because other day itself I told you, according to latest labor care guide of WHO, active phase starts at 5 centimeters. And we all know, other day when I took class on induction of labor, oxytocin is not a very good inducing agent. That's why I would like to change that terminology slightly as /any oxytocin, which includes misoprostol. I hope Arul Kumaran sir excuses me for this, but I think in the recent light of labor care guide and the method of inducing labor, I think it's appropriate to convert this 4 centimeters into 5 centimeter, oxytocin into any oxytocin. I hope you all agree with me. Now, we have done with the successful induction. But then we cannot forget the probability of achieving vaginal delivery was the original intention, right? So, in women who progressed into active labor within 12 hours, as per the definition of Arul Kumaran sir, 67 to 86% of them delivered vaginally, which means if they get into active labor early, the chance of vaginal delivery is more. Whereas, if they progressed into active labor within 18 hours, another 6 hours grace was given, the chance of vaginal delivery is less, almost half of it, 31 to 33%. That means if they take longer time to get into active stage of labor, the chance of vaginal delivery is less, chance of cesarean section is more. So what I have done now with this additional knowledge to the same definition, again, I'm claiming myself, I have not published it anywhere. It is my deduction, my perspective. So putting that timeline given for achieving active phase of labor and combining the probability of vaginal delivery, depending upon how early they get into active phase of labor, I have tried to frame a time to achieve active labor as I construe, that's why that word I've used, 12 to 24 hours. I am giving something like WHO giving lot of grace time. 12 hours is the minimum. That is what we saw just now. 67% of them will get into labor. 24 hours, I have gone beyond 18 hours because I have got two reasons to do this. One is based on just the previous slide. Second one is FIGO guidelines. What do you mean by that? Can you recall this slide of mine when I gave a lecture on induction of labor? You see all the protocols per vaginal, 6th hourly, maximum 4 doses. That means 24 hours. So unless you have tried maximum number of doses, which is permissible in FIGO guideline, how can you just say that she's not got into active labor? In fact, as I told other day in the class, we have seen in Manipal, and I'm sure it's the experience of most of us, that after 4 doses, that is after 24 hours, we don't jump into cesarean section. Sometimes I've, many times rather, not sometimes, many times I've told, let's just wait. Don't do anything now. No more induction. And we're just waiting in another 3 to 4 hours, either they have ruptured the membrane spontaneously, or they have got into active labor on their own. Or sometimes we allow her to sleep the overnight. The next day morning, we start again. And then within first tablet itself, she'll get into active phase of labor. I'm going to talk more about this in the later slides, that what happens when you wait for some more time. So that's exactly why it is necessary for us to give an adequate amount of time. But what is the disclaimer? What is the bottom line? I'm sure you can guess that. The disclaimer is mother should be healthy. There should not be no maternal distress. Fetus should be healthy. There should not be fetal distress. And obstetrician should not be in a hurry. That is no obstetrician distress and no patient party distress. So when everybody is aligned, you can give that optimum or judicious time for the lady to get into actual labor and try to avoid a cesarean section. But that doesn't mean that you must avoid cesarean section at any cost. No, you should be judicious. That's the meaning of it. So what are the factors that influence the success of induction of labor? Gestational age. I have explained this enough and more in my induction class and initiation of labor. Higher the gestational age, better, because the ratio between estrogen and progesterone changes in favor of estrogen, and estrogen will bring in prostaglandins. Prostaglandins will make the muscle fibers more sensitive towards oxytocin and whole lot of things. Bishop score, of course, the single factor, higher the better, more than 5 in the 10 score, that is maximum 10, is always better. Cervical length by ultrasound. What about this? You may think that what is the difference between Bishop score and cervical length? Bishop score takes other 4 factors, not only the length. Whereas cervical length by ultrasound, not an effective or at most a weak predictor for any of the outcomes assessed, because there are a lot of fallacies in assessing the cervical length by ultrasound. Fetal fibronectin, as I have told you, it increases just before delivery. So if it is more fibronectin, then the chances of induction being successful is more. Presence of infection. Whenever there is infection, the outcome is poor because the oxygenation is poor for the muscle fibers to act. So there are newer predictors now. The light-induced fluorescence. It's a measure of cervical collagen. That LIF, light-induced fluorescence measurement, correlate negatively with gestational age and positively with the time of delivery. So at the time of delivery, it is more. The correlation, however, was weak. So that's why we cannot really swear on this until more studies are done. What about elastography? That's another new thing that has come. It determines the motion in areas of cervix relative to others, defining a elastography index, EI, what we call. Those with successful induction of labor had a higher EI of internal loss. But then the next point is slightly contradictory. That is, higher rates of cesarean in those women with a higher E. This is slightly difficult to digest, these two sentences. Successful induction means higher EI, but higher EI also does not always mean that vaginal delivery. Higher rates of cesarean has been also seen. EI at interloss is not useful in predicting vaginal delivery is another controversy. So that itself means this has to be studied properly. A technical limitation is that this measurement still depends on the force exerted by the operator. So it is good to know that the newer predictors have come, but a lot of studies have to take place. Probably I will have to give a lecture next time using these two predictors. What are the factors influence success of induction of labor? We were so far talking about the success of induction of labor in terms of achieving active phase of labor. But despite a large number of studies conducted, no good predictive factors were found to successfully identify the group of patients who will not respond to physical or pharmacological induction. So you can only think sort of laterally or indirectly, gestational age, Bishop score, and so many things, including the newer ones, LIF and the elastography. But till today, we do not have a real good indicator. So the next point is the factors determining the outcome. You have successfully induced labor, all right, but what is the outcome? The outcome people expect whether she landed up in vaginal delivery or in cesarean section. You may have successfully induced ovulation, but patient does not care. Patient cares only whether you have achieved pregnancy or not, or given a baby or not. That's why successful induction is one thing. Successful outcome in terms of vaginal delivery is another. So what are those factors? The rate of cesarean delivery increases with higher gestational age. Higher gestational age is good to have successful induction, but higher gestational age, you may land up with more cesarean deliveries despite achieving success. I hope I'm not confusing. It is very, very clear. The reason also I've given in bracket, higher fetal intolerance to labor. You have achieved labor only to put fetus into distress. Maybe naturally, even in natural labor, higher the gestational age, the baby goes into distress because the placental drug comes down. And bigger baby also as the age advances. This I have explained properly in the induction of labor or initiation of labor. Maternal age, what is the reason? Maternal age directly correlates with the medical complications like preeclampsia, diabetes, and all sorts of things. So maternal age also determines the final outcome. You may land up in cesarean section despite achieving good labor with successful induction. BMI, bigger the baby, bigger the mother, bigger the baby, and more maternal complications with BMI. So you may achieve labor, but the outcome may be cesarean section. Birth weight and AFI by ultrasound. So higher the birth weight of the baby, you may induce labor, successful induction. AFI also higher, so you may land up with cesarean section. Sudden rupture of membranes, cord prolapse. That's the thing. Some more. It also depends upon what was the indication to induce. Don't get confused. You have taken a decision to induce, you have induced successful induction. But the outcome depends upon what was the indication. Suppose the indication to induce was PPROM, you may land up in cesarean section also, not always vaginal delivery. PROM near term with pulmonary maturity, you may be successfully delivering vaginally. Preeclampsia, FGR oligohydramnios, labor induced successfully, land up in cesarean section because of fetal distress. So intention was to give vaginal delivery. We don't want to straight away do cesarean section, but we can't say whether this baby will withstand the stress of labor. So we have to take a call considering everything. If it is severe FGR, better not induce, straight away go for cesarean. That's what I told in the previous talk also. If it is oligohydramnios less than 3, why induce, straight away take for cesarean section? Because we know that that baby will go into distress. It is already showing that there is a chronic hypoxia. On top of that, the severe contractions will induce acute hypoxia on chronic. So what was the indication to induce also influence the outcome. I hope by now we have clearly understood the difference between the successful induction and outcome of induction. They are different. They are not same. Though the original intention of induction was to give a vaginal delivery only. But then that has to be understood clearly. The intention was to give vaginal delivery because we didn't want to straight away do cesarean section just because she was not in labor. Am I clear? Or in a preeclampsia, where we want to primarily think of the mother because her BP is increasing, you should not just because severe preeclampsia go and do a cesarean section. First try whether she can deliver vaginally. And of course, in the course of labor, if there is a fetal distress, you may land up into a cesarean section. That is another issue. Okay. So post-term gestation, again, same thing happens, successful induction happens, but you may land up in cesarean section. Elective. Most of the time, elective inductions, they are not really going to have a lot of complications. Okay, so becoming frequent these days. So what are the outcomes based on? There is potential benefit for the mother, obviously, when you induce, because you're avoiding a cesarean section or fetus that easily supersedes the IOL. If you recall my definition of IOL in that class, what is induction of labor? Induction of labor is done to induce a labor in a non-laboring woman for the fetal benefits and maternal benefits, and they should supersede the risks. So that fits the bill here. Cesarean and assisted vaginal delivery rates are not increased by induction of labor at term when medical indication exists. So that is the Cochrane review, but it's going to change slightly in the next slide. In elective inductions, the risk is very low, as I told in the previous slide. Maternal and fetal complications are low because it's electively done and there are no medical complications. So just that she has probably gone past dates or 41 weeks, you want to give a vaginal delivery for her. So what are the tips to reduce adverse outcome in elective inductions? Even though the risk is less in elective induction, despite low risk of maternal and fetal complications, favorable cervix and obstetrical conditions should be prerequisite when indicating elective induction of labor in order to further decrease the potential adverse outcomes associated with the intervention. So already it is low, but you want to bring it further low. So look at the cervix also before inducing. Rates of cesarean section for failed induction. Higher rate of maternal fetal morbidity, especially with an increased risk of cesarean section, was associated with induction of labor. That is the observation, as I told you, the things may change against the Cochrane review. Cesarean rates does not increase or even decreases with the policy of IOL at or beyond 41 weeks of gestation, in addition to improving perinatal outcomes. Clearly, in this particular slide, there are two controversial outcomes. So what it means is that don't blame the induction of labor. Look at what was the indication of induction. If it was medical indication where already there is a compromise to the mother, to the fetus, the outcome may not be what you expected with the induction of labor. That's all it means. Conflicting results reported between 40 and 41 weeks. Let us not worry much about this particular slide. Is cesarean section a must for failed induction of labor? This is what I was telling in the beginning. Should we always do cesarean section just because we are finished with the induction and she's not getting into labor? Failed induction of labor diagnosis at a given point of time does not always involve performance of immediate cesarean in all centers. Depends upon your capacity to monitor. If you have good PGs, if you have good SRs, you can still continue with doing induction or wait for some more time. Because studies have shown that continuing the induction beyond a failed induction of labor will lead to vaginal delivery in a considerable number of patients. Here is the statistics. You see, in first one, young, the failed induction was 12 cases, it is 11.4%. But by waiting further, the cesarean sections were only 8 cases, that is 7.6. In the other study, 55 patients were diagnosed to have failed induction, but only 5 of them went for cesarean section by waiting some more time. 15 patients in Park study, only 2 went for cesarean section. This is what I meant by saying that don't give up that easily. Don't say 12 hours, 18 hours, 24 hours. Don't say like that. You can wait for a good, adequate number of time as long as mother, baby are all right. So time to achieve active labor, I consider I bring this slide back again, 12 to 24 hours based on these findings. So finally, my take is that a judiciously chosen case based on proper medical obstetric indication to induce, after assessing the cervix and using appropriate method of induction with close monitoring, is bound to succeed in achieving active labor in most cases. Further, patience and perseverance may increase the number of vaginal deliveries, which is the ultimate goal of induction. I hope I have done justice to whatever I have read and understood, and this is my final perspective. Thank you very much.